Welcome to my presentation titled COPD Care That Fits, Developing Patient-Centric Treatment Plans. My name is Terrence Shenfield, and I am the co-owner of A&T Respiratory Lectures. I hope you enjoy this presentation because I have a lot to offer here. I want to give you a little background. We all know what COPD is, which is basically chronic obstructive pulmonary disease. It is a chronic lung condition that obstructs airflow and it makes it very difficult to breathe. It includes disease like emphysema and chronic bronchitis and is often caused by smoking or long-time exposure to irritants or even genetic factors. The symptoms of COPD include shortness of breath, chronic cough, wheezing, and progressively gets worse over time. Now, the role of patient-centered care. Basically, patient-centric care is a healthcare approach that prioritizes the individual needs and the preferences and values of patients. In other words, it really personalizes the treatment plans offered to the patient. It fosters open communication, and it really wants to have active patient involvement with patient decision. The goal is if you improve patients' communication and you have the involvement with decision making, you improve overall patient satisfaction, you also improve your outcomes, and also your overall quality of care being treated to the patient. So this is a very important portion of the healthcare plan for patients with COPD. And I think the combination, if you have a patient with COPD and you offer them patient-centric care, you're on the right direction. In today's presentation, the objectives are, I'm going to be talking about what is COPD. I'm also going to be talking about the significance and burden of COPD on the patient as well as society. I'm going to be talking about some of the risk factors involved with COPD. I'm going to be talking about treatment options, and the treatment options are going to be the traditional treatment options and also future treatment options involved with patient care. Also, I'm going to be talking about the role of education, understanding exactly what kind of disease process you have and how to manage it is ultimately important, and this all ties into patient-centric approach. So I'm going to tie all of these qualities of this lecture together and hopefully come up with something that you enjoy and you learn from. Let's talk about COPD. Exactly what is it? Basically, chronic lung obstructive disease is a progressive long-term lung condition that restricts airflow and it makes breathing very difficult. The main cause of COPD is prolonged exposure to irritants such as cigarette smoke, air pollution, workplace dust, or even chemicals. Some of the core conditions of COPD, basically it encompasses two main disease processes. One is called chronic bronchitis, which is basically airway inflammation, and emphysema, which is actually the destruction of the lung airway sacs or the alveolar. So these are the core conditions caused by COPD. Now, the symptoms of COPD typically vary. The typical signs is a persistent cough, difficulty breathing, wheezing, and excessive mucus production. And finally, we get about into the damage that is caused by COPD. Although lung damage from COPD cannot be reversed, treatments are available to help alleviate symptoms and enhance the quality of life. So the idea is you really can't reverse the damage caused by COPD, but you could certainly manage the symptoms, and they got some really good stuff out there to help you with that. Let's talk about the prevalence of COPD. COPD is a leading cause of morbidity and mortality worldwide. It's not just here in the United States, everywhere across the country and also across the world, people have COPD. It affects approximately 390 million people globally, and it has significant variations in prevalence across regions. In other words, every country is not the same. So, for example, in the United States, it's been shown that COPD in adult was approximately 3.8% with women and 4.1% with men. So it looks like women have more COPD than men. Let's talk about the age factor. With regarding to age, the prevalence of COPD increases with age, particularly affecting individuals over 40 years of age. And the highest rates are observed with people who are over 60. In the United States, some of the COPD prevalence is about 0.4% with those aged 18 to 24 and 10.5% with age 75 or older. And you could get into different demographics about Asian and non-Hispanic adults, but that's generally the significance of COPD. Let's talk about gender differences. Historically, COPD was more common in men because more men smoked, but the gap is narrowing as smoking rates among women has risen, and also there's exposure to indoor air pollution, which actually remains a very significant risk factor. Let's talk about geographic variations. For example, COPD prevalence is higher in lower to middle income countries where exposure to risk factors such as biomass fuel smoke and occupational hazards is more common. Also, they found regionally different things with here in the United States between the Midwest and the South and versus the Northeast and the West. So, regional and socioeconomic variations do make a difference. Let's talk about the undiagnosis of COPD. COPD is often underdiagnosed, and with many individuals unaware they even have COPD until it progresses to the severe stages and then they don't know what to do with it. So, actually, many people across our country have COPD and they don't even know it, and the time they really know about it, it's almost the damage is done. So, let's also talk about economic and healthcare impact on COPD. COPD imposes a significant economic burden due to its direct health care costs like hospitalizations, medications, and long-term care, as well as indirect costs from loss of productivity and premature mortality. So it really strains the healthcare system in this country. And you can read the stats right here for that in the United States. But it really impacts the resource utilization globally, and it has a high impact on morbidity and mortality in the world. Let's talk about the significance and burden of COPD. And some of the areas we're going to cover with this is reduced quality of life, the cost of healthcare needs, the emotional and mental strain, the progressive physical decline, and the impact on social work life. So let's first talk about the prevalence and public health impact. COPD affects over 16 million Americans, with millions more potentially who are undiagnosed, making it a leading cause of chronic illness in the United States. It impacts daily activities such as working because it gives you're breathless, you got a chronic cough, you're fatigued, which makes it really challenging. Also, the economic burden of COPD imposes a significant financial strain with direct healthcare costs exceeding over $32 billion annually. And then you also got to consider indirect costs. Indirect costs come in the form of loss of productivity, and this adds to billions of dollars too. Actually, patients with COPD have increased healthcare needs. They often require medical attention, they have frequent hospitalizations, they need oxygen, they need medications, and so this really adds up when you really think about everything. Now let's talk about the mortality rates. COPD is the fourth leading cause of death in the United States. It accounts for over 150,000 deaths annually, and really that's a really high number due to something that could be caused by cigarette smoking. This causes emotional and mental health strain. The chronic nature of COPD leads to anxiety, depression, and the feeling of isolation. So this really impacts you all the way around. When you talk about the quality of life, COPD significantly reduces patients' quality of life because basically what they have persistent breathlessness, they have fatigue, they have frequent hospitalization, and all of this adds up to emotional and physical distress. And we all know that COPD is a progressive disease. What that means that over time, the symptoms get worse. And as the symptoms get worse, your quality of life gets worse. And then another thing you really got to think about is disparities in care. What that means is the burden of COPD disproportionately affects certain populations, such as older adults, smokers, and then individuals with lower socioeconomic money or groups. This emphasizes the need for targeted prevention and treatment efforts. So really, COPD as a burden is really significant, and I covered some of the basic things you need to know about it. Let's cover some of the pathophysiology of COPD. I'm not going to go into a lot of details with this, but I'll go to enough for you to understand it. So the hallmark sign of COPD is chronic inflammation. Long-term exposure to irritants like cigarette smoke and environmental pollutants can lead to inflammation in the airways, alveolar, and blood vessels in the lung. This results in tissue damage and structural changes. Another thing that happens is called airway narrowing. Airway narrowing is caused by the inflammatory processes that cause excessive mucus production, thickening of the airway walls, and enlargement of the smooth muscles. All of this restricts airflow and makes breathing more difficult. Another thing that goes on is alveolar destruction. The breakdown of the alveolar walls, as seen in emphysema, decreases the surface area available for gas exchange. What this does, it leads to reduced oxygen absorption and impaired removal of CO2. So that is some of the major problems that go along with COPD. Another problem with COPD is reduced elasticity. What that means is that the lung tissue is damaged and has diminishes the natural ability to spring back during exhalation. So what happens is when you inhale and you breathe out, the lungs doesn't fully exhale. And what this does, it actually causes air to be trapped and leading to overinflation of the lung. So you can see this very clearly in the X-ray, which you'll see flattened diaphragms. And finally, we get into pulmonary vascular remodeling. What that means is prolonged low oxygen levels and inflammation leads to changes in the structure of the pulmonary blood vessels. What it does, it increases resistance in the pulmonary circulation and potentially can cause pulmonary hypertension. So all of these things add up to the pathophysiology of COPD. I know I only touched on it briefly. But I wanted you, this lecture is more about patient-centric care, and I'm just giving you an overview of what COPD is. Let's turn our attention to some of the risk factors for COPD. And the main categories of risk factors is smoking, environmental exposure, genetic factors, respiratory infections, and age and gender. So let me go a little bit more details. When you think about smoking, it's the leading cause of COPD. Smoking damages the lungs and airways, and it significantly increases the risk of developing the disease. This includes both active smoking and long-term exposure to secondhand smoke. So even being around someone who smokes for a long time can actually impact your probability of getting COPD. Let's talk about environmental exposures. Prolonged exposure to air pollutants such as industrial fumes or dust or chemicals or indoor pollutants such as biomass fuel used in cooking or heating can contribute to airway dysfunction and COPD. You never know it, but someone who is constantly around automotive fuels can really get COPD too, as well as someone who cooks in a restaurant and they're exposed to all the grease and all the type of pollutants that come in the air. Another factor is genetic factors. And I'm sure you all have heard of alpha 1 antitrypsin. Basically, a deficiency in the protein alpha 1 antitrypsin is known to be a genetic risk factor for COPD. And it can predispose individuals to lung damage, even often without the risk of smoking. So some of these people who don't even smoke, but if you happen to have a deficiency in this particular gene, you could actually develop COPD. Respiratory infections, some patients who are born premature, who develop into adults, frequent or severe respiratory infections during childhood can also impair lung development and actually can make you more likely to develop COPD later in life. So, sometimes it's respiratory infections as birth. If you a lot of times patients who are born with chronic lung disease as a child end up getting COPD later in life. And then we get into age and gender. Um, you know, as you get older, when an individual becomes over the age of 40, um, they more likely develop COPD. And in the past, it was more prevalent with men, but now it affects women at similar rates due to changing in smoking patterns and environmental exposures. So, these are some of the risk factors of COPD, and you should certainly avoid the ones you can, and some you can't, and that's life. That's how it works. Let's talk about the common symptoms of COPD. And it's very easy to read. You have shortness of breath or dyspnea, you have chronic cough, you also have wheezing, you also have frequent respiratory infections, and you also can experience fatigue. So let's get a little bit more into detail. Shortness of breath or dyspnea, this is when you experience difficulty breathing, especially upon exertion. So if you do any kind of physical activity and you get really short of breath and you don't have no cardiac condition, this is a primary indicator of COPD. Also, a chronic productive cough, not just a chronic cough, but something that is productive. A long-standing cough, often accomplished by mucus production, is commonly sometimes called as a smoker's cough. So basically, if you've been coughing for a long time and you're bringing up mucus and you have a smoking history, good likely chance you might have COPD. So then another common symptom is wheezing. Wheezing is basically a high-pitched whistling sound during respiration. So as you breathe out, you'll hear an exhalation, you'll hear a wheeze sound. And actually, this is a result from airway constriction. And finally, we get into recurrent respiratory infections. Basically, patients with COPD have a heightened vulnerability to such respiratory symptoms such as colds, influenza, and other respiratory conditions. And finally, with patients who are COPD, they feel fatigued. And the reason for feeling fatigued is persistent tiredness or low energy levels, and basically it stems from the increased effort of breathing and diminished oxygen supply to the body. So these are some of the most common symptoms of COPD. There are probably some other ones out listed, but this just gives you a general idea of what's going on. Let's talk about how do you diagnose COPD. And I broke this down into two parts, and then I got a summary slide to show you more information. So the best way to diagnose COPD is with the Global Initiative for Chronic Lung Disease, commonly called the gold standard. So the gold standard, again, is called the Global Initiative for Chronic Obstructive Disease. And basically, they came up with some guidelines for diagnosing, managing, and treating COPD. And I'm going to break down some of the evidence-based recommendations they make from it. So one of the first things they do is they want to get a clinical history and a symptom evaluation. So basically they look at the patient history. They gather information about the patient's exposure to risk factors such as smoking, which is the most significant risk factor. They want to access the duration and intensity of smoking. How many pack years have you done? They also look at environmental and occupational exposure. For example, they can inquire about long-term exposure to air pollutants such as chemical fumes, dust, or other occupational hazards. Finally, they look at family history. And family history is really important because you got to consider genetic predispositions such as alpha-1 antitrypsin deficiency, which can increase the likelihood of getting COPD. The second thing they look at symptom assessments. And basically symptom assessment you could evaluate the presence and the progression of hallmark symptoms. What are the hallmark symptoms? I expressed that a little bit earlier. I talked about chronic cough. They want to know how often, when did you get your first symptom? Is it intermittent or is it persistent? They also might look at sputum production. Basically, they want to know the frequency, the volume, and the characteristics of the sputum. And finally, they look at dyspnea, or how shortness of breath you are. And basically, it's a progressive symptom that worsens over the time, and also it can worsen during physical activity. The next part of that, we get into what is called spirometry testing. I'm going to get a lot more into spirometry testing, but regarding the diagnosis of COPD, the purpose of spirometry is to confirm the presence of persistent airflow limitations, which is a defining feature of COPD. So basically what they do, they conduct a post-bronchodilator spirometry to measure lung function. And some of the key metrics they look at the ratio of forced expiratory volume in 1 second, commonly known as FEV1, to forced vital capacity, commonly known as FVC. A post-bronchodilator FE1 FVC ratio of less than 0.70 is persistently consistent with the confirmation of airway limitation. So they also sometimes do a post-bronchodilator study. And you may ask, why are they doing a post-bronchodilator study? And that basically, they could tell the difference between the airflow limitation being caused by asthma or COPD. If the airflow limitation is reversible, it's not COPD. If the airflow limitation is reversible, it's most likely asthma. Regrettably, sometimes some patients have a combination of asthma and COPD, which makes it really tough to diagnose. This is the second part on how to diagnose COPD, part 2. It's actually a continuation of the first part. So another very important way of diagnosing COPD through the gold standards is the assessment of disease severity. Basically, once COPD is confirmed, they want to classify the severity of airflow limitation using FEV1 percentage of predicted value. So the idea is they could determine whether you had gold level 1 or gold level 2 or gold level 3 or gold level 4 based upon your FEV1 value. So I'm going to go in a little bit more detail on the next slide, but gold level 1 has an FEV1 of greater than 80% of predicted. Gold level 2, which has a level of 50 to 79% of the FEV1 predicted value. A gold 3, which is severe, has an FEV1 of 30 to 49% of predicted, and gold 4 is an FEV1 less than 30% of predicted, which is the worst kind. Another thing they look at symptom burden and risk assessment. And basically what that means is they look at a modified medical research council, commonly known as the MMRC dyspnea scale. And this scale measures the impact of breathlessness on daily activities. They have another scale called the COPD assessment test, CAT, which is basically a comprehensive questionnaire assessing the overall impact of COPD on people's life. There are some risk assessments. Risk assessments can be to review the patient's history of exacerbations, and such as do they have worsening symptoms requiring medical interventions, frequent exacerbations, or do they have greater than 2 a year, or 1 hospitalization for COPD exacerbation or even higher. So these are some of the classifications made, and now I'm going to get a little bit more into what is called the gold group classification. The gold group classification basically combines the symptom burden of the 2 scores I told you about, the MMRC and the CAT score, and they look at your exacerbation history to categorize you into one of 4 groups. You could be in Group A, which is low symptom burden, low risk of exacerbations. You could be in Group B, which is high symptom burden, low risk exacerbation. You could be in Group C, which is low symptom burden, high risk exacerbation. Or you could be in Group D, which is high symptom burden, high risk exacerbation. And basically, you have to exclude certain alternative diagnoses during this process. In other words, you may think you have COPD, but you may have asthma, you may have heart failure, you may have interstitial lung disease. And each of these are ruled out through a different method. So, reversible airflow limitation is a hallmark sign of asthma. Regarding heart failure, that you could do an echo and you can find out if that's the problem. In regard to interstitial lung disease, you got to do some CAT scans, and that can show that kind of abnormality. And so different things they could do imaging on chest x-rays, they could look at hyperinflation, they could look at structural changes typically of COPD. They could even do blood tests. And when they do a blood test, they could be testing whether you have the alpha-1 antitrypsin deficiency, and this could give you a more readily diagnosis. So you could see that the diagnosis of COPD can be quite complex, especially using the gold standards. But when you really do it, this is a real evidence-based approach to what kind of COPD you have, how long you had it, the burden it has on you, what level you have, and then based upon that, what kind of treatment plan you could have. So this was a little background. I'm sure I could go a lot deeper into it, but I think we covered it pretty well. So let me go into a little bit more detail about the gold standards, and particularly I'm going to go through each stage. And you may ask, why is this important? You got to remember the GOLD, which is called the gold standard, stands for Global Initiative for Chronic Obstructive Lung Disease. And basically, a group of medical professionals put together this program so that you could actually measure effectively each stage of the severity of airflow limitation. So when you think about COPD and you think about airflow limitation, based upon that limitation, which is measured by spirometry, you can guide the management and the treatment of the disease. And you may ask, why is that important? Why should you know what stage you are? When you think about it, this is really important for patient-centric care. You could tailor the treatment plan based upon the stage they're on. So for example, if a patient is in Gold 1, they may only require lifestyle changes and occasional bronchodilators, while a patient is Gold 4 may need oxygen therapy, pulmonary rehab, and maybe even more intensive interventions like non-invasive ventilation. So based on your stage and based on the severity of your stage, that is where your treatment option will go. Another thing very important about the gold standards is disease progression tracking. In other words, you can look at a patient who's identified in GOLD 1 over the time, and you could sort of see if they go to stage 2 or stage 3, and hopefully never go to stage 4. And early detection of the progression can prevent complications because you can actually manage the symptoms better. So if you see someone go from stage 2 to 3, maybe you could up your medications with them, and this way they can really manage their life a lot better. So when you really think about GOLD 1, that is considered mild. And how that is predicted, they do an FEV1, which is a spirometry test. So if the FEV1 is greater than 80% predicted, and your symptoms are minimal, like, you really don't get shortness of breath, occasionally, maybe if you do some extra work, you may have a chronic cough, but it's not always noticeable. And a lot of times at this stage, a patient doesn't even realize they got COPD. So GOLD 1 is mild. It's measured by spirometry. Your FEV1 greater than 80% is predicted. The symptoms are often minimal. But at this point, a lot of patients don't even know they have COPD. Now, when we progress into GOLD 2, that's a whole different story. GOLD 2 has a spirometry test that is greater, it's less than 50% of the FEV1, but it's also less than 80% of predicted. So if it's less than 50% of the FEV1 and it's less than 80% of predicted, that is a sign of GOLD 2. During this time, you'll have increased shortness of breath. You can get physically exerted. If you do some kind of physical exercise, you're going to get exerted. You will have a cough with sputum production. And at this stage, you're going to really start paying attention to your symptoms. You're going to realize that you are not doing well and you need to be managed a little bit more effectively. Now let's turn our attention to gold standard 3 and 4. Remember, GOLD 2 is moderate, and basically that's when your FEV1 is between 50 to 79% of predicted, and you have noticeable shortness of breath. When you get into stage 3, that is labeled severe. That means that your FEV1 is between 30 to 49%. It actually of predicted values. You definitely have significant shortness of breath. You have frequent exasperations. What do I mean by frequent exasperations? That means you could be sent to the emergency room, and you also can have reduced quality of life. And this is when you would step up your therapy for the patient and step up your education. You would actually do it all stages, but this is when you start really paying attention. And finally, we get into GOLD 4, and this is very severe. That means that when your FEV1 is less than 30% of predicted or is 50% with chronic respiratory failure. The symptoms are there. You have severe symptoms. You're extremely short of breath. You can't walk from your couch to the refrigerator without getting short. You have great limitations in your quality of life. You have frequent hospitalizations. At this stage, a lot of these patients end up having long-time oxygen therapy or long-term oxygen therapy. They might also use non-invasive ventilation. It really impacts their life. And actually, at this point, probably stage 3 and stage 4, you're going to be depressed, which is quite understandable. If you can't breathe, you're going to be depressed. Now let's turn our attention to disease progression. You have COPD and you're gradually getting worse and worse. So we all know that COPD is a declining in lung function. Over time, your lungs are going to get worse and worse. It progresses rather slowly. Basically, breathing becomes a little bit more difficult, and this is mostly due to inflammation and obstruction. And that's what the major cause of the decline in lung function. Also, you have a problem with a reduction in your oxygen intake. Oxygen, because of the destroyed alveolar, you don't get all the oxygen in your body, and that's why you get the fatigue. Another really problem with the disease progression is frequent exasperations. What do I mean by that? I mean you're going to get flare-ups, And these flare-ups, they accelerate lung damage, and they also increase hospitalization, and they also worsen your overall health. And as it advances, this disease, you're going to get more and more of these flare-ups, and you're going to probably be in the hospital more and more, which is sad, but it's a reality. And then another really important factor is reduced physical activity. You know, people who have COPD are typically older. They're typically, a lot of times, they may even live alone. They have to go to the store to shop. They have to get food. They have to do like normal activity that we take for granted. Because their breathlessness and their fatigue, it limits their physical activity. So basically, a lot of them are stuck at home. And when you're stuck at home, this results in muscle weakness and a decline in overall fitness. Basically, you're not going out and walking, you're not going to the gym, you're not doing this, you're not doing that, you're not visiting your family. And this really, it really is a decline in your overall fitness. Finally, we get into it can actually reduce any of your activity levels that you do. Anything that you've done in the past is going to be reduced. Now, all of this leads to emotional and psychological strain. You know, you got to understand, if you can't go see your friends, you can't shop, you're not eating right, you have, limited mobility, the idea of this is going to lead to anxiety, it's going to lead to depression and social isolation. So all of these things significantly impact your mental well-being. All of this adds to a diminished quality of life. And you don't enjoy life anymore. You don't enjoy all the things you normally wanted to do. So I wanted to sort of elaborate a little bit more on the emotional and psychological strain of COPD, and I'm going to give you some headlines or some ideas about the topic. So, as I mentioned, there's definitely a great strain on you physically, emotionally, and psychologically. These people typically have chronic anxiety. If you can't breathe or you're breathless, you're going to be feeling anxiety. Any of us would. Also, you get depressed because you feel hopeless. You feel like because of the physical limitation and reduced quality of life, you're depressed. You just sit home, you do nothing. This leads into social isolation. Social isolation is you avoid social activities because you're embarrassed by your physical inability. You don't want to be sucking wind in front of people. And then again, this leads to frustration and anger. It leads to a loss of independence. And sometimes it even leads to guilt. And you say, how does this feel guilt? Because a lot of people who have COPD, they blame themselves. If they had a smoking history, they say to themselves, what an idiot I was. Why did I do all these things? So with that being said, there are certain things you should do. One of the things that can really help these patients is pulmonary rehab, and I'm going to get a little bit more into that, which combines exercise, education, and support, and actually improves the emotional well-being. Another thing that could benefit them is counseling and therapy. Cognitive behavior therapy has actually been shown to be very helpful in managing anxiety and depression. And then you got support groups, and then you can also consider mindfulness and relaxation techniques. All of these things can alleviate stress and anxiety with these people. And you have to understand, if they don't utilize that, they're going to spiral downhill all the way. So now let's turn our attention to the current treatment approaches for managing COPD. Bronchodilators are the foundation for the management of COPD, and it comprised of certain groups. We all heard of long-acting bronchodilators, such as long-acting beta agonists, LABAs. We all heard of long-acting muscarinic antagonists, LAMAs. These are central to the management of COPD. They are preferred over short-acting maintenance therapy. So the idea is you don't take albuterol every 2 hours to manage your COPD. And a lot of times they do combinations of both LABAs and LAMAs. These are good for persistent symptoms with patients. Then there are times what we call triple therapy for severe cases. So when you're in stage 3 and stage 4, or gold standard 3 and 4, These patients have severe symptoms. They have frequent exacerbations, so they really need a triple therapy. So they get a mixture of LABAs, LAMAs, and inhaled corticosteroids. This approach actually shown as evidence to reduce hospitalizations. It also improves the quality of life. It also enhances lung function, and it reduces exacerbations. So these are the cornerstone approaches how you would manage COPD. Now, in the next slide, I'm going to talk about some new pharmacological options that are being generated from 2025. So let's talk about some of the new pharmacological options we have. They just came up with some new guidelines in 2025 to incorporate different treatment options into the therapy for patients with COPD. And a couple of them were a phosphodiesterase inhibitor. This is the PDE3 and the PDE4. Basically, this offers anti-inflammatory benefits to the patient. Another targeted therapy is like biological targeting is the eosinophilic inflammation. So basically, some patients have a high eosinophilic inflammation process going in their lungs, and they have certain medications to decrease that kind of inflammation. So this is very personalized biological treatments that are treated to patients. Another thing that's really important, which we're going to get into when we talk about patient-centric care, is patient treatment adjustments. What that means is treatment plans are customized based on factors like eosinophil levels, exacerbation history, prior therapy responses, and a lot of times patients are given erythromycin if they are non-smokers, but they have frequent exacerbations, and also they have another medication that is good for chronic bronchitis. It's called roflumilast, and basically these two medications are cutting edge and everything like that. Now, another possibility to do is give vaccinations. You know, people who get older should get the RSV vaccination. They should get a pneumococcal vaccination. They get the influenza vaccination. All of these things really add up to reducing the likelihood of exacerbations with COPD. These are some of the most cornerstone treatment options you have out there. So there are some good non-pharmacological treatments that patients can take. And we all heard of pulmonary rehab. Basically, pulmonary rehab is someone would go 1 or 2 times a week to a center, and they would do physical training, they would do education, and they'd have some kind of support system to help them with their condition. The benefits to this is improved physical fitness, reduced symptoms, and enhanced quality of life. I could do a whole lecture on pulmonary rehab, but I just wanted to give you an idea of the non-pharmacological treatment you could do. Another very important thing is smoking cessation. Hopefully, if someone has COPD and they smoked their whole life and they're still smoking, they need some kind of support. They need counseling, they need behavioral therapy, they need nicotine replacement. A lot of patients who have COPD in severe cases don't continue to smoke, but if you do, you definitely need to get in some kind of smoking cessation program. A third very important item is nutritional support. You know, if you don't eat well and you don't get the nutrients in your body, you're going to suffer more. Crazy as it was, my mom had COPD, and her favorite dish was tea and toast. You know, that's carbs. You know, carbs increase the likelihood of getting CO2, and that's, not the best thing. So this lecture is not about the nutritional support needed, but understand that you really need to eat well. You got to prevent malnutrition. You got to prevent obesity, and this will improve your energy levels and your overall health. And then finally, we get into breathing techniques. Breathing techniques such as pursed lip breathing or diaphragmatic breathing can really help a patient with their breathlessness. And finally, if they ever need oxygen therapy and ventilation support, this is what you got to do. Especially, if someone has a little bit of obstructive sleep apnea and COPD, they call that overlap syndrome, and you go to sleep at night and you would normally desat with the OSA, and all of a sudden you got COPD, your levels of saturation go down to dangerous levels, and there's going to be some kind of sympathetic response where your heart rate's going to go up and your blood pressure is going to go up. Not a good thing. If you happen to need oxygen therapy and ventilation support, you got to do it. A lot of patients who are at home with COPD, severe cases, use non-invasive ventilation at night. I really make it easy to understand how to manage COPD as healthcare practitioners as we are. We know what you should do, we know what you shouldn't do. But if you're the actual patient who has COPD and you have to adhere to some kind of regimen, that could represent a problem. And some of the most common problems we have or challenges with COPD management is early diagnosis and awareness. What happens is COPD is often underdiagnosed or misdiagnosed. Some people think you have asthma when you have COPD, and what happens, you get progressively worse. Sometimes you can have overlap conditions, and again, this could really delay treatments. Like I mentioned before, if you have OSA and you have COPD, that's overlap syndrome, and a lot of times this is misdiagnosed and mistreated. A lot of times patients don't adhere to the treatment regimen. Sometimes these are complex. There's many different medications you got to take different times. They have to use proper inhaler techniques. That's where education comes really important. They have to take a bunch of medications. They got to remember which medications they're taking, and they also have to change their lifestyle. They got to eat well. They got to do some exercises. And if you don't adhere to this, you just really spiral out of control. Then exasperation and hospitalizations. Frequent exasperations, when you don't manage yourself well and you don't really take care of yourself well, you're going to be hospitalized more. You're going to have a reduced quality of life. You're going to have your disease progress is just going to go faster and faster. So it's really not good, really good. So prevention and management are critical to improving outcomes. And then a lot of times, people who are older with chronic COPD have other conditions. They can have comorbidities such as cardiovascular disease, diabetes, anxiety. All of this requires a multidisciplinary approach, which could be quite challenging. And then finally, a lifestyle and environmental factors. Sorry about that. The smoking cessation, air pollution, occupational exposure. If you have a partner who smokes and you have COPD, that's not the best thing in the world. If you have a cat and you're allergic to, the dander, that's not a good thing. So you got to change your lifestyle and make adjustments to really benefit from managing COPD. So now let's get into the heart of this lecture. We're going to talk about what is patient-centric approach. Patient-centric care, also known as patient-centered care, this originated as a response of the traditional provider-focused healthcare model. So basically, in the past, the healthcare provider would just tell the patient what to do, and this is what they do, and they follow it. Its roots can be traced back to several key developments in healthcare philosophy, ethics, and practice over the 20th century. But the real background of this comes from humanistic psychology back in the 1950s and 1960s. And basically, the concept of patient-centric care was influenced by humanistic psychology, particularly the work of Carl Rogers and Abraham Maslow. They emphasized the importance of empathy, individual needs, and self-determination, which align with the principles of patient-centered care. When we talk about patient-centric care in COPD, this focuses on tailoring healthcare needs to the patient. So basically, the healthcare needs of this patient will be individualized based upon their preferences, their values, and rather than following a one-size-fits-all approach. It emphasizes collaboration between the patient and the healthcare provider. And what this does, it empowers the patient to take an active role in managing their condition. So this is the basis of that, and I'm going to get a little bit more into the details that follows. Patient-centric care involves treatment plans that are customized to fit each patient's unique needs, lifestyle, and personal goals, ensuring both an effective and meaningful care plan. Patients are encouraged to actively participate in their care decisions, working collaboratively with the healthcare providers to select the most suitable treatment options, much different than we did in the past. Basically, you need to have clear and accessible education about COPD, its management, and self-care strategies. So the key point here is you educate someone and then you give them self-care strategy. This care extends way beyond physical symptoms. It addresses emotional, psychological, and social challenges in a well-rounded approach to COPD management. And basically, you look at the you look at the progress of the patient, you look at the symptoms of the patient, you look at the treatment effectiveness, and they are continuously monitored and changed or adjusted based upon how the patient feels. And what you really want to do is enhance their outcomes and, most importantly, improve the quality of their life. One of the key concerns of patient-centric care is shared decision making. This is the basis of this type of care. And so what you really want to do is you want to empower patients through education. You want to educate them very well. You want to make personalized treatment plans for them so they can make their own decisions on what kind of treatment they take based on evidence-based practices. You want to encourage lifestyle modifications, let them know what they can participate in and what they know they can't. You want to manage exacerbations and symptoms, and you also want to foster emotional and social support. So if you understand COPD and your treatment options, so one of the first things you got to do is you got to educate your patients about COPD, its progression, and the available treatments to help them make informed decisions about their care, like choosing the medications, the therapies, and lifestyle changes they need to do. You also need to create customized care plans. And what do I mean by that? Patients and healthcare providers need to work together to design treatment plans that match individual needs, such as selecting the right inhalers, the right heat rehab program, and oxygen therapy based on symptoms and lifestyle. Also, you want to teach the patient to adopt healthier habits. What do I mean? Patients are encouraged to make positive lifestyle changes, such as quit smoking, of course, staying active, eating well, and all of this can improve lung function as well as quality of life. And then you need to be able to manage your symptoms and your flare-ups. When you recognize the early signs of flare-ups, such as you're getting short of breath, or if your peak flow is really bad, or if you're really having a hard time, you need to recognize this and then maybe up your medications so that you can manage it better, so you don't end up in the emergency room. And then also you really want to do is you want to build emotional and social support. And how you do this, you address mental health challenges like anxiety and depression is key. If you manage these, the patients will be better connect about their care, they'll understand what they're doing, and they'll become more resilient. So these are some of the ideas you need to know with shared decision making. Let's elaborate a little further on personalized treatment plans based upon patient-centric care. So basically, when we talk about that, we're talking about comprehensive patient assessment, we're talking about tailored medication regimens, you're talking about lifestyle behavioral interventions, you talk about monitoring and adjustments, and you also need to talk about patient education and support. So regarding patient checkup, you need to start with a full review of the patient's health history. You need to know their lifestyle and how severe their COPD is based on the goal stages. Also, this includes spirometry tests and also checking other health issues. If you have any kind of comorbidities such as heart disease and diabetes, these can identify other triggers that could, make your condition worse. Also, you need to customize medications. When you prescribe medications like bronchodilators, steroids, or inhalers, these got to be based upon the disease stage. So, in other words, you won't offer an inhaled corticosteroid if they don't need it at first. So, customizing medications tailored to the patient's condition is all about patient-centric care. Also, you really want to focus on healthy habits. As I mentioned earlier, you want them to quit smoking, you want them to eat better, you want them to get some good sleep, and you want them to stay active. Rehab programs are great for this. And then you need to do regular check-ins. You need to schedule follow-ups with the patient to adjust their patient's condition and base their needs based upon where they're at. So sometimes you might even put tools like wearable devices to help monitor oxygen levels and activity. Sometimes you could put a pulse oximetry and do some spot tests to see how their oxygenation status. And then the cornerstone of this is education and support. You really need to teach the patients how to use an inhaler correctly, how to use oxygen, how to create a plan for emergencies. Also, even keeping a home decluttered and everything like that. All of this is really helpful. All of this is patient-centric care. The final arm of patient-centric care is to offer nutrition advice. They have unique nutritional needs. So some of the basic things you need to understand in patient-centric care is they need to have proper nutrition to sustain energy. Eating the right food supplies the body with the fuel needed for everyday tasks, and it'll give them the extra energy they need for the demands of breathing. When you have COPD, you're breathing hard, you're working harder, so you really need energy stores in the form of nutrition to help you breathe. You need to maintain muscle health. You need to have a diet that's high in protein so that you could build muscles, both respiratory and skeletal muscles. And these are vital for proper breathing and physical movement. You also need to eat food that can be anti-inflammatory, like, for example, omega-3 and fruits and vegetables. These are great ways to reduce inflammation and enhance lung performance. And finally, we want to boost your immunity. And how do you boost your immunity? You boost your immunity through essential nutrients such as vitamin C, vitamin D, with zinc, and all of these things fortify the immune system, and it actually decreases the likelihood of respiratory infections that could aggravate COPD symptoms. And finally, you got to control your weight. You want to keep a balanced weight. You don't want to be overweight. You don't want to be too thin. You want to be, normal weight, and you do want to have muscle. Why do you need muscle? Because it reduces the work of breathing you need to do while you have COPD, and you're going to be working harder because you need to oxygenate your body. So these are some of the basic tenets you need to understand about nutrition with COPD and how you need to manage it, and it's all part of patient-centric care. In conclusion, I want you to understand how patient-centric care with COPD can be quite beneficial to change that strategy, to have the patient involved in their own decisions, to have them involved with understanding the education and the progression of their disease, and adopting approaches that could benefit them in the long run. Also, you have to remember there are some really cutting edge treatments out there. Rehab is not cutting edge, but they got new phosphodiesterase treatment options, biological treatments that could work very well. I just talked to about nutrition. Nutrition is the cornerstone. You need proper nutrition for the energy levels you need. And all of this comes through educating your patient. You need to educate your patient to understand everything. And don't forget that you need to deal with their emotional issues, and especially if they're isolated. A lot of these patients with COPD live by themselves and they're isolated. They have anxiety, they're depressed, so you really need to understand that. So this is the basis of patient-centric care, and I hope you enjoyed this presentation. I want to thank you for joining my presentation, and my presentation was based on these references plus many more. If you need more references, I'll be more than happy to share them, but thank you very much for joining me.